So I think the ideal situation for patients is what we'd call personalized medicine. I take your tumor, I analyze it, do sequencing, and I say, okay, this is the exact treatment that's going to work for you, and that's all you need. We know that bladder cancer is complicated. The average tumor in the TCGA had 7 mutations, and so it's hard to say, oh, just this one drug is going to work. It's possible even a combination of drugs won't work. And if you think about the treatments that we currently use, chemotherapy and even immune therapy, they're relatively non-specific. They're not targeted. Chemotherapy kills dividing cells, and that's why it causes toxicity, right? We get nausea because our stomach cells are dying, or we lose our hair because our hair cells are dividing. We become anemic because our blood cells are dividing. So it's a very non-specific therapy. And even immune therapies work non-specifically. We stimulate the immune system. It's supposed to find these cancer cells and fight them. But we also have stimulation of the immune system, so people can get rashes, they can get GI side effects, and get pneumonitis, they get high blood pressure. And what you ideally want is a targeted therapy that just affects just the cancer and nothing else. Now, being that the most active agent right now is cisplatin, it would be nice to know who is most likely to respond. And cisplatin works by causing DNA damage. And if your cancer can repair its DNA, then it might be able to resist cisplatin-based chemotherapy. And so there have been several studies looking at which genes can predict response to chemotherapy. Dr. Plimac's group looked at a panel of DNA repair genes, ATM, FANCI, PRB, and found that those were strongly predictive of response to chemotherapy. Dr. Rosenberg's group looked at ERCC2, which also is involved with DNA repair, and also found that that was a significant predictor of response and survival. If you look at those genes at the TCGA, about 38% have had one of the DNA repair gene abnormalities, and ERCC2 was found in about 10% of bladder cancer patients. So these genes are not uncommon, and if we can validate these findings, then we might be able to use them to help select patients. Dan Theodorescu described the Coxon principle, which looked at gene expression modeling to try to predict response, and was able to find that he could predict who would respond to cisplatin-based chemotherapy quite well. And there's a SWOG trial that is looking at validating this Coxon principle and also looking at other markers potentially. The trial is finished accruing. It's SWOG 1314. And when we have the results of that, it's quite possible that these findings will be used in clinical care to try to select therapy for patients. The nice thing now is that the pure study results came out and showed that immune therapy might be active as a neoadjuvant chemotherapy. So if you're a patient and I analyzed your tumor and said you're unlikely to respond to chemotherapy, you could go and get immune therapy perhaps, or you could go straight on to cystectomy, for example. So I think these are going to be very useful clinically and probably improve our ability to decide which treatments to give to which patient.